Till now, we have seen about the intraoral technique which is used for the mandibular nerve block. This class we will see about the extraoral techniques which is available for the mandibular nerve block. The extraoral technique, in extraoral technique, the most common area will get anesthetized will be the temporal region, auricle of the ear, external auditory meatus, temporomandibular joint, salivary glands, anterior two-third of tongue, floor of mouth, mandible, lower teeth, gingiva, and the buccal mucosa, and the lower portion of the face, except at the angle of jaw. What are all the anatomical landmarks for the extraoral techniques, which includes midpoint of the zygomatic arch? This picture shows that midpoint of zygomatic arch, zygomatic notch, coronoid process of ramus of the mandible located by opening and closing of the jaw, lateral pterygoid plate. When it is indicated, it's most commonly desirable to anesthetize the entire mandibular nerve and its subdivision with one needle insertion and minimum of anesthetic solution. When infection or a trauma make insertion of the nerve subdivision difficult or impossible, diagnostic or therapeutic purposes. In these cases, extraoral technique is most commonly indicated. The technique includes the procedure should be carried out in a aseptic condition, similar to that of all the techniques where we are using, so it should be under the aseptic condition. See, palpate the midpoint of the zygomatic process is located and the depression in its inferior surface is marked. So this is a pictorial representation, shows that the region where you have to palpate. When you palpate here, you can able to locate the mandibular nerve. So that is this, the midpoint of zygomatic process is located and the depression in its inferior surface is marked. With the 25 gauge needle, the skin is raised just below this mark in this depression. Using 8.8 centimeter needle attached to the Lulock type of syringe, measures 5 centimeters, marks with the rubber marker. Out of 8 centimeter needle, you have to mark the 5 centimeter of that needle with a rubber marker and insert the needle into the depression where you have seen below the midpoint of the zygomatic process. The needle is inserted through the skin wheel perpendicular to the median sagittal plane until the needle point gently contacts the lateral pterygoid plate. The needle should never be inserted beyond the depth of marker. It means that beyond 5 centimeter, the needle should not be inserted. The needles withdrawn with only the point left in the tissue and redirected in a slight forward and upward direction until the needle is inserted to the depth of the marker. After a careful aspiration, 2 or 3 milliliter of suitable anesthetic solution is slowly injected. Care should be excised to aspirate after 0.5 ml solution is injected. So the care should be taken after aspirating the solution. You have to inject the sufficient amount of anesthetic solution in that region. The needle passes through the structures which includes skin, subcutaneous muscle, masseter muscle, mandibular notch, external pterygoid muscle. What are all these symptoms? It includes the subjective and objective symptoms. Subjectives includes tingling and numbness of the lower lip, anterior two-third of the tongue. Objective is instrumentation to demonstrate the presence of anesthesia. So this is the extraoral mandibular nerve block. The only landmark is the depression below the midpoint of the zygomatic process. So just remember that is the landmark for the extraoral technique. Coming into the extraoral mental and incisor nerve block. The nerve which get anesthetized will be a mental nerve and then incisor nerve. Area anesthetized will be a lower lip, mandible and overlying buccal and the labial structures anterior to the mental foramen. Mandibular teeth anterior to the mental foramen. Anatomical landmarks includes bicuspid teeth, lower edge of the body of the mandible, supraorbital notch, infraorbital notch, and the pupil of eye. When it is indicated when anesthesia of mandibular teeth and the labial and the buccal supporting structures anterior to the foramen and the lower lip is desired and the block of inferior nerve is contraindicated. What is the technique? The technique includes the patient should close the mouth in a normal position and they should look straight forward. So this picture shows that the patient has to look straight forward. Palpate the supraorbital notch and the infraorbital notch palpated and it's located. With the patient looking straight forward, an imaginary line drawn from the supraorbital notch, foramen, through the pupil of eye and the infraorbital notch or a foramen will continue downwards, passes through the mental foramen. So you have to draw a straight line when the patient looks forward. Draw a straight line from supraorbital notch, infraorbital notch to the mental foramen. So the midway point between the lower border of the mandible and the gingival margin is estimated on the imaginary line. So this should locate the mental foramen. After the skin is raised at this point, 22 gauge needle is slightly introduced in an anterior and in a downward direction. With the gentle probing, the mental foramen should be located and entered. 1 millimeter of anesthetic solution should be adequate to produce a sufficient anesthesia. The needle will passes through the following structures include skin, subcutaneous tunnel tissues, triangularis muscle. So this is a picture that shows the region where you are going to block the mental nerve. So first you have to draw a straight line along the supraorbital, infraorbital notch, infraorbital foramen through the mental foramen. The midway between the lower border of the mandible, and this is a picture shows that the midway between the lower border of the mandible and the gingival margin is located. It's marked first. Once it is estimated, mark imaginary line and then locate the mental foramen. Coming into the symptoms, the patient will have a tingling and numbness of lower lip on the site where it has been injected. Objectives will be the instrumentations will demonstrate the presence of anesthesia. Coming into the masseteric nerve block. So this picture shows the steps involved in the masseteric nerve block. First steps is the visualization of width of the ramus by grasping the anterior and the posterior border with help of thumb and the middle finger. See, using this index fingers, locate the zygomatic arch at the point halfway between the thumb and the middle finger. The index finger moves inferiorly until you reach the mandibular notch. So the needle is introduced posterior to the index finger, hitting the neck of the condyle. So I hope you people understood with the help of this picture. First picture shows that you have to measure the width of the ramus by grasping the anterior and the posterior borders with the help of the thumb and the middle finger. The second picture shows that the index finger is used to locate the zygomatic arch at the point halfway between the thumb and the middle finger. The third one shows that the index finger should be moved slowly inferiorly until you reach the notch. Once you have been reached the notch, introduce a needle posteriorly to the index finger until you hit the neck of the condyle. Once you hit the neck of the condyle, deposit the local anesthetic solution slowly. Coming into the extraoral technique by the Kurt and the Thoma. This method is given by Kurt and Thoma. The patient is asked to clench the teeth and the lowest point on the anterior border of the masseter is located. A line is drawn from the point of tragus of the ear to the midpoint of the, so that you have to draw a line from this point to the tragus of the ear, where the anterior point will be the anterior border of masseter of the muscle. From there you have to draw a line to the tragus of the ear. The midpoint of this line which marks externally the mandibular foramen. The line is drawn from this point parallel with the posterior border of the mandible. This line is measured and 21 gauge needle of 6 to 8 centimeter length is marked to similar length by means of piece of a rubber dam. The long needle is now inserted on inner aspect of lower border of mandible. The needle is gradually inserted parallel with the line marked on the skin on external surface. When it reaches to the depth indicated by the marker, that the opposite the point marked on the skin, overlying the position of foramen, the solution is slowly injected. So from this picture, I hope you people can able to correlate the wordings and the picture. You have to draw a line from the anterior border of the masseter muscle to the tragus of the ear. So the midline, so this is a point where the midline has been marked. So the midpoint should be marked, which indicates the region where the foramen has been located. The line is drawn from this point. So from this point, you have to draw a line paralleling with the posterior border of the mandible. So this is a picture. This is the wording states that the line is drawn from the point parallel with the posterior border of the mandible. So you have to draw a line. So paralleling with the posterior border of the mandible. Once you have drawn the line, so the needle is inserted parallel with this line. So this picture shows that you have to insert the needle paralleling this line extra orally. So once you have been injected the needle, so you have to insert the needle up to 6 to 8 centimeter of the marking. So beyond that, you should not insert the needle. Once you have been insert a needle from extra surface of the mandible, slowly deposit the solution. Pin index indicated. Curtainthoma is most commonly indicated as a severe limitation of opening of jaw, TMJ ankylosis. Coming into the intraseptal injections. So this is a few accessory injections which includes intraseptal. The nerve anesthetized will be the terminal nerve endings at the site of injection and in adjacent soft and hard tissues. Area anesthetized will be the bone, soft tissue, root structures in the area of injection. When it is indicated, when both pain control and the hemostasis are desired for soft tissue and osseous periodontal treatment. Contraindicated infections are severe inflammations at the injection site. What are all the advantages? Lack of lip and tongue anesthesia. Minimum volume of local anesthetic solution is required. Minimized bleeding during the surgical procedures. A traumatic immediate onset of action and the few post-operative complications. And it's used on a periodontally involved teeth. Disadvantages: multiple tissue punctures is necessary, bitter taste of the anesthesia, shorter duration of pulpal anesthesia, limited area of soft tissue anesthesia, clinical experience is required. Posterior aspiration is 0%. Alternate to this, you can either give pedial injection in the absence of infection or a severe periodontal involvement and then intraosseous anesthesia, regional nerve block with a local infiltration for hemostasis. Technique is that 27 gauge needle is recommended. Area of insertion is this. The picture shows that the area of insertion, center of interdental papilla adjacent to the tooth to be treated. Target area are the same. Landmark is papillary triangle about 2 mm below the tip, equidistance from adjacent teeth. Orientation of the bevel towards the apex. Procedure: assume the correct position, which varies significantly from tooth to tooth. The administrator should be comfortable, have adequate visibility of injection site, and maintain the control over the needle. Positioning the patient should be supine and semi-supine, with the head turned to the maximum access and the visibility. Prepare the tissue at the size of penetration. Dry with the sterile gauze. Apply topical antiseptic. Apply topical anesthesia for a minute. Stabilize the syringe and orient the needle correctly. Frontal plane 45° to the long axis of the teeth, and the sagittal plane at the right angle to the soft tissue. So these are all the accessory techniques. I have added these slides only in the exam point of view. So I hope few points from this may or may not come for you as a neat questions. Bevel facing the apex of the tooth. Slowly inject a few drops of local anesthetic as a needle enters the soft tissue and advance the needle until you contact the bone. While applying a pressure, push the needle slightly deeper into the interdental septum. Deposit the sufficient amount of local anesthesia, not less than 20 seconds. So only thing is that in case of intraseptal injection, you have to inject in between the teeth along the interdental papilla. So just remember that alone. So coming, the two important item indicates the success of interseptal injection, which includes significant resistance and ischemia of the soft tissue. Signs and symptoms, as I told, ischemia of soft tissue is the subjective. Resistance to the injections will all be the signs and symptoms. Coming into the intraosseous, is IO, intraosseous technique, the nerve anesthetized will be the terminal nerve endings at the site of injection and in adjacent soft and hard tissue. Area anesthetized will be the bone, soft tissue, root structures in the area of injection. Indication: pain control for dental treatment on single or multiple teeth in a quadrant. Contraindication is infection or severe inflammations at the injection site. Advantages is lack of lip and tongue anesthesia, atraumatic, immediate onset of action, few post-operative complications. Disadvantage: requires a special syringe, which is called stabident or X-tip intrafloor. Bitter taste of anesthetic solution. Occasionally difficult in placing anesthetic needle into the pedal hole. High occurrence of palpitation when a vasopressor containing local anesthetic is used. Positive aspiration is 0%. Alternate periodial injection in the absence of infection or a severe periodontal involvement. Intraseptal injection, supraperiosteal injection, or a regional nerve block. Technique. So just look at the picture. Just select the injection site at a 0.2 mm apical to the intersection lines. Draw horizontally along the gingival margin of tooth and vertically through the interdental papilla. Locate the site and slowly injected the solution. Avoid injecting into the mental foramen area. So this is a vertical perforation technique for edentulous area. Perforate at the point on the alveolar crust, mesial or distal to the treatment area. It is also called as crustal anesthesia. Sometimes you may get a questions stating that which is a crustal anesthesia technique. It is nothing but vertical perforation technique of intraosseous technique for edentulous areas. So as I told that there is a special needle has to be used. What is that only the disadvantage of using this? This is the stabident intraflow. I've shown a few points. I've added this to show you what is this intraflow anesthetic system. So it's recently introduced, combines two steps. Intraflow handpiece is attached to the standard 4-hole air hose on a treatment room delivery. The intraflow is specially modified slow speed handpiece. It consists of four main parts: needle or the drill that makes a perforation, transfuser that acts as a conduit for local anesthetic cartridge, a latch tip or a clutch that drives and governs the rotation of needle, a motor and infusion drive that powers the rotation of needle or a drill while holding the local anesthetic cartridge in a place, powers the infusion plunger, and 25 gauge dual bevel needle is provided. This is the intraflow delivering system. Sometimes you might get a question, picture-based question, stating that this picture indicates what? This picture indicates the intraflow delivery system. So this is a part, just remember the parts. So this is a procedure. Prepare a tissue at the injection site, apply a topical anesthetic, place a bevel of the needle against the gingiva, inject a small volume of local anesthetic solution until blanching occurs. Check a soft tissue anesthesia using cotton pilers. Cotton pilers leave a slight dimple marking at the site. Inject a few drops into the dimple. Perforate the cortical plate by using the needle. Activate the handpiece using a gentle pecking motion on the perforator until the sudden loss of resistance is felt. Cortical bone will be perforated within a 2 seconds. Hold the guide sleeve in a place as the drill is withdrawn. Withdraw the perforator and dispose it safely. Inject into the cancellous bone. It is easy to insert the needle into the hole. Press the tapered needle gently against the guide sleeve to minimize the local anesthetic leakage. Compress on a cotton roll or 2x2 sterile gauze against the mucosa to observe any of excessive local anesthetic solution. Slowly and gently inject the solution. Signs is subjectively, the patient will have ischemia of soft tissue. Objective is use of pulp testing. You have to check whether there is a response or no response. So this is the stabident dosage. So sometimes they may ask you a question. So I have added this tabular column stating that to anesthetize one teeth, the injection site is distally or immediately mesial. Two adjacent teeth between the two teeth. Three adjacent teeth immediately distal to the middle tooth. Stabident maxilla dosage to anesthetize injection site, one tooth immediately distal or immediately mesial. Two adjacent teeth, if you want to anesthetize, you have to give the injection between the two tooth. If you want to give anesthetize four teeth, you have to inject in the midway between a two teeth distal and two teeth mesial. Coming into the intrapulpal. The nerve that is anesthetized will be a terminal nerve index at the site of injection in the pulp chamber. Areas tissue within the injected tooth. Indication: when a pain control is necessary for pulp extirpation or other endodontic treatment. In the absence of adequate anesthesia from the other techniques. Contraindication is there is no absolute contraindication. The intrapulpal injection may be the only local anesthetic technique available in some clinical situations. Advantages is lack of pulp and the lack of lip and tongue anesthesia. Minimum volumes of anesthetic solution is necessary. Immediate onset of action. And then the patient will have very few post-operative complications. Coming into the disadvantage, it includes traumatic. The intrapulpal injection is associated with a brief period of pain. Bitter taste may be difficult to enter the certain root canals. Bending of needle may be necessary. A small opening in the pulp chamber is needed for optimum effectiveness. Large area of decay may make it more difficult to achieve performed anesthesia with the intrapulpal injections. Posterior aspiration is 0%. Coming to the technique, insert the 27 or 25 gauge needle into the pulp chamber or a root canal as needed. Ideally, the wedge the needle firmly into the pulp chamber or root canal. Occasionally, if the needle does not fit snugly into the canal, in this situation, anesthetic can be deposited in the chamber or canal. Anesthesia in this case is produced only by the pharmacological action. Deposit the anesthetic solution under the pressure. A small volume of anesthetic solution like 0.2 to 3 ml is necessary for successful intrapulpal anesthesia. If the anesthetic stays within the tooth, so that ml is more sufficient. In many situations, anesthetic simply works back out of the tooth into the aspiratus. Resistance to the injection of the drug should be felt, then the needle if necessary to gain the access to the pulp chamber. Signs and symptoms. As with PDL, interceptor and IO, no subjective signs and symptoms ensures adequate anesthesia. Objectives will be endodontically involved teeth may be treated painlessly. So these are all the few amount and what are all the tooth and what are the anesthesia has to be given for each tooth and what are the soft tissue to anesthetize the soft tissue. In case if you want to anesthetize as the buccal or lingual soft tissue, in case of mandible you have to give IA and B. For incisive alone you have to give a pulpal anesthesia. For canine you have to give an inferior alveolar nerve block. So this is the table column which will minimize and summarizes the which tooth requires which nerve block and which in the region of soft tissues which region requires the which nerve block. I hope like everyone understood what are the techniques which are available for maxillary nerve block, the mandibular nerve block, and what are the complications which is involved in the local anesthetic solutions, and what is the local anesthetic solution, how does it works, and what are all the mechanisms involved in the local anesthetic solutions, and what are the classifications available for the local anesthetic solution. Thank you.